Welcome to episode 36 of the Pro PA podcast. I'm your host, Prof. G. Today, we're breaking down acid-base interpretation using my version of the Rome method, which is a simple and effective tool to understanding arterial blood gas or ABG results. We'll focus on a stepwise approach that simplifies acid-base interpretation, making it easy to answer PANCE-style questions and apply this knowledge in clinical practice. Remember, while acid-base physiology can be complicated, you don't need to know advanced equations to answer most exam questions or manage basic cases. Let's get started. First, let's look at the Kinderpatho. What are acid-base disorders? Well, acid-base disorders occur when there's an imbalance of the blood's pH, and this is caused by changes in either one of two things: the PaCO2, which is the partial pressure of carbon dioxide, controlled by the lungs and the respiratory component of acid-base disorders, and HCO3 or bicarbonate, which is controlled by the kidneys and controls metabolic component. Now, what are some of the key terms to remember when we discuss acid-base disorders? First, the pH. This indicates acidity or alkalinity. The normal pH ranges between 7.35 and 7.45 in the human body. Anything less than 7.35 is considered acidosis, where everything greater than 7.45 is considered alkalosis, and this is very important to understand. Number 2, PaCO2, or partial pressure of carbon dioxide, we'll refer to as carbon dioxide from now on, reflects ventilation and respiratory control. Now, the normal CO2 levels are going to be between 35 and 45. And I remember this because normal pH is 7.35 to 7.45. Then I remember that the CO2 levels are going to be 35 to 45. So if we have an elevated PaCO2, it's acidic, so that would indicate a respiratory acidosis. If I have a low PaCO2, it might indicate a respiratory alkalosis. So carbon dioxide you can think of as acidic. The more carbon dioxide you have, the more acid you have. The less, the more alkalytic it is. Okay? Now let's look at HCO3 or bicarbonate. This is regulated by the kidneys and it reflects metabolic function. And normal bicarbonate is going to be between 22 and 26. So anything with a low bicarbonate is going to indicate more of a metabolic acidosis. If you have a high bicarbonate, this is going to indicate a metabolic alkalosis. All right. So now let's look at the Rome method for acid-base interpretation. Now there are many different approaches to looking at acid-base interpretation, but I feel like the Rome method is one of the simplest ways to just get it down and remember it long term so that you can recall it when you need to on the PANCE exam. So the Rome mnemonic is a simple way to interpret acid-base, and basically it stands for RO, stands for respiratory opposite. So in respiratory disorders, pH and PaCO2 move in opposite directions. An example of this would be a pH that's low, a PaCO2 that's high, and that would indicate a respiratory acidosis. Now, the ME in ROME or Rome is going to stand for metabolic equal. And in this case, we mean that metabolic disorders, a pH and an HCO3 or a bicarb move in the same direction. An example of this would be if you have a low pH and a low HCO3, this would indicate a metabolic acidosis. If you don't get it yet, don't worry. We have a stepwise approach to acid-base interpretation where I'll try to guide you through the different steps to assess whether something is acidic or alkalytic and then figure out whether it's respiratory or metabolic. So here is my sort of version of a 4-step approach based on the Rome method. So step 1, you need to decide, is the blood acidic or alkalotic? And the way to determine that is to first look at the pH. If the pH is less than 7.35, it is acidosis. If the pH is 7.45 or more, It is alkalosis. And so what I'd like you to do when you first approach a question is to look at that pH. If the pH is low, write a down arrow, an arrow pointing down, and write acidosis. You got half of it right now. If you have an alkalosis or a pH greater than 7.45, I want you to write an arrow pointing up, and I want you to write down alkalosis. Because again, you have 50% of the equation if you can figure out whether it's acidosis or alkalosis. And then from there, you can figure out what's actually causing that pH abnormality. So step 2, you want to determine the primary disorder. You got to figure out, is it the PaCO2? Is it the carbon dioxide? Or is it the bicarb that's causing this issue? Is it a respiratory problem or a metabolic problem? So with respiratory acidosis, if the pH is low, the PaCO2 will be high. It's opposite, okay? If it's a respiratory alkalosis, the pH will be elevated, the arrow will be pointing upward, and the PaCO2 will be pointing downward. That's opposite. Now, for the metabolic, we would want to see the arrows pointing in the same direction. So if the pH is low, I would expect to see the bicarb to be low as well, and they would be equal. Same thing with metabolic alkalosis. If the pH is up, the HCO3 or the bicarb will also be up, and that would be equal. That is the simplest way to look at it. When you get into some of the more complex compensations and things like that, it is easier if you truly understand the reasoning behind this. But let's just take it one step at a time. So, step 3, evaluate for compensation. So, the body often attempts to compensate for acid base imbalances, but compensation is rarely complete. So, if you have respiratory compensation, the lungs will adjust the PaCO2. And if you have metabolic compensation, the kidneys will adjust the HCO3. Now, the lungs can adjust the amount of carbon dioxide a lot faster than the kidneys can adjust the bicarb levels, because we can essentially adjust our carbon dioxide by the rate and depth of breathing. Now, another thing to think about here is that true compensation, complete compensation, is going to have actually a normal pH. So if we notice that the pH is normal, the patient doesn't look good, and there are some abnormalities in the bicarb or the carbon dioxide, think of a compensated problem. Step 4, consider the anion gap, and this is if it is metabolic acidosis. So I don't expect you to have to calculate an anion gap, but just so that you know how to do it. So the formula for an anion gap analysis is you're going to want to take sodium and you're going to subtract the chloride plus the bicarb from that sodium. So you'll take chloride, add it to bicarb, then you'll subtract that from the sodium. A normal anion gap is going to be between 8 and 12. And we might see a normal anion gap in something like loss of bicarb due to like diarrhea. And then an elevated anion gap is anything greater than 12. And this is usually because of acid production like lactic acidosis or DKA. So what are some common acid-base disorders? Well, metabolic acidosis, you're going to have a pH that is low, right? It's an acidosis. And you're going to have an HCO3 or bicarb that is also low. Remember, same, equal. They're going to be equal. So they're both going to be low. An anion gap, again, is key to differentiate whenever you have metabolic acidosis, because the differential diagnosis changes whether it is a elevated anion gap or a normal anion gap. And I have a couple mnemonics here for you to help you remember the different causes of the elevated anion gap and the normal anion gap. So first, let's start with the elevated anion gap. And the one that everyone knows for this is MUDPILES, MUDPILES. The M in MUDPILE stands for methanol. The U stands for uremia. The D for DKA. The P for propylene glycol. The I and H or iron. The L, lactic acidosis. E, ethylene glycol. And S, salicylates. So those are going to be your causes for elevated anion gap metabolic acidosis. Now, for a normal anion gap, there's another mnemonic here, and it's called hard ups, HARDUPS. And so for this, the H is going to be hyperalimentation, the A, Addison's, R, renal tubular acidosis, D, diarrhea, U, ureteral diversion, P, pancreatic fistula, and S, saline infusion. All right, moving on to metabolic alkalosis. So in an alkalosis, remember we would expect the pH to be high. And because it's a metabolic problem, we expect the arrow to be pointing in the same direction, which means that the bicarb should also be high. Causes of metabolic alkalosis include loss of acid, so like persistent vomiting or nasogastric suctioning, or excess bicarbonate due to something like diuretic use or antacid overuse. All right, now let's get to the respiratory. So first we have respiratory acidosis. So that is a pH that is low, right, an acidosis, and a PaCO2 that is high, it's opposite. And the causes of this are going to be hypoventilation. So COPD, drug overdose, and certain neuromuscular disorders. Now let's look at respiratory alkalosis, last but not least. The pH, as in all alkalosis, is going to be high, and the PaCO2 is going to be low, opposite. Now, causes of respiratory alkalosis are going to be hyperventilation, like anxiety, pain, fever, and pulmonary embolism. Now let's do a quick example case so that we can apply the row method ourselves and see how we do. So we have a 35-year-old female who presents with confusion and dyspnea. An ABG reveals a pH of 7.28, a PaCO2 of 55, and an HCO3 of 25. So let's go ahead and do those 4 steps, that step-by-step interpretation. So number 1, the first thing we need to look at is the pH. So a pH of 7.28 is less than 7.35, which is the lower limit of normal. And so when it's low like that, we have an acidosis. So we want to write that little arrow pointing downward, and we want to write the word acidosis. Got half of it right now. All right, step 2, which is the primary disorder? So first let's look at the CO2. Normal is going to be from 35 to 45, and we see that the CO2 is elevated. It's 55. And that is opposite of the low arrow that we saw for the acidosis. So if respiratory is opposite, it's more than likely a respiratory acidosis. But we want to look at bicarb anyway, just to see what it's looking like, and it is normal. So we see a bicarb of 25, and the normal range is between 22 and 26. So number 3, we're looking for compensation. HCO3 or bicarb is normal, indicating no significant compensation, as well as the pH is not normal. Now, diagnosis. What would you think can cause something like this in a 35-year-old patient with confusion and dyspnea? Well, we said with respiratory acidosis, we can see it due to things like hypoventilation for any particular reason. All right, so quick book med versus street med. Book med textbooks are going to focus heavily on compensation equations and mixed acid-base disorders. It can get a little more complicated than what we've seen today, but not much more. You all have the basis. You should be able to get 90% of the questions right on PANCE exam. Now, street med, start simple. Start with the pH, look at the PaCO2, look at the bicarb, and use the row method because it's pretty reliable and easy to remember and easy to apply in most real-world situations. All right, quick clinical pearls. Use the row method to determine the primary disturbance, respiratory opposite, metabolic equal. For metabolic acidosis, always calculate the anion gap to narrow the differential. Now, number 3, compensation is rarely complete. If the pH is normal, think a mixed disorder. And most PANCE questions focus on recognizing primary disorders and basic compensatory patterns. All right, let's move on to our knowledge check. So first question we have is a 25-year-old man who presents with nausea and abdominal pain. His ABG reveals a pH of 7.3, a PaCO2 of 33, an HCO3 of 18, a sodium of 140, and a chloride of 100. What is the most likely diagnosis? Is it A, metabolic acidosis with anion gap, B, respiratory acidosis, C, metabolic alkalosis, or D, respiratory alkalosis? I'll give you a few seconds to think about this one. If you said A, metabolic acidosis with an anion gap, you are right. So the low pH and the low HCO3 suggest a metabolic acidosis. The low PaCO2 indicates a partial respiratory compensation. And the equation also gave you that sodium and chloride so that you could calculate whether or not they had an anion gap. And in this case, they did. All right, question 2. A 50-year-old woman with COPD presents with confusion. An ABG reveals a pH of 7.35, a PaCO2 of 52, and an HCO3 of 32. What is the acid-base disorder? Is it A, respiratory acidosis with metabolic compensation, B, metabolic acidosis, C, a mixed disorder, or D, normal ABG? I'll give you a few seconds to think about this one. If you said A, respiratory acidosis with metabolic compensation, you are right. So we noticed that the pH is at the lower limit of normal. It is 7.35, but we do see an elevated PaCO2, and that is acidic. Okay. The pH is also more on the acidic side, but we also see that HCO3 indicates a compensated respiratory acidosis. So we see the bicarb is up also, but that is more basic. So that's the compensator. The CO2 being high is the primary cause. So that's how we know that it's respiratory acidosis with a metabolic compensation. All right, I want to thank you for joining me on this episode. I hope it helped you understand how easy acid-base interpretation can be with the revised row method that we came up with. If you want to take a deeper dive into acid-base interpretation with visual aids, check out my lecture on my YouTube channel, Professor G PAC. And stay tuned for more high-yield clinical topics. Don't forget to follow this podcast and turn on notifications so you never miss an update. And as always, this is the Pro PA Podcast, where future pros in medicine are made. I'll see you soon.